But yeah. So we're just starting to record now. I have got a presentation that I'll share on the screen, which hopefully, if you've got any questions, by all means ask. But I do appreciate that it's not always the type of subject that people feel confident or comfortable talking about, particularly if they're in a group. But see you guys at Pinderfield. You look like you're pretty well behaved, so I'm quite happy. If you want to ask questions, fire away as well. But hopefully, as I go through the presentation, some of the questions might be answered for you. But I think the aim really is just to explain a little bit about why it is that when you have a spinal cord injury, that sexual function is affected, and also just how it's affected in different ways depending on what your level of spinal cord injury is. And I guess I'm not going to go into too much anatomy, physiology. I want to try and keep you awake. And I think that the most important question that I often get asked is, people aren't really interested in the anatomy, physiology side of things. They just want to know, can I get an erection? If so, how do I get one? So I'll sort of talk a bit about that in a bit more depth, and just talk about the fertility side as well, and just what information is out there. And I'll drop an information sheet into the chat function later on, which will just have various links to other sources of information, because I'm very conscious of the fact that if you go onto Google and just start typing in sexual function, spinal cord injury, we want to try and make sure that we can signpost you to good, accurate information, rather than just opening up a complete minefield of information that might be quite overwhelming and to try and wade through. But like I say, do ask questions. I'm more than happy to answer any questions that you do have. If you don't feel happy asking questions in a format like this, I will leave our contact details at the end of the presentation. So you can always just get in touch with us individually, and we're more than happy to talk to you on a one-to-one basis. I probably ought to start off by just introducing myself. That'd probably be quite useful. So I'm Damian Smith. I'm the spinal cord injury nurse specialist covering the south and southwest of England, southern counties of Wales. I'm one of 6 spinal cord injury specialists now at SIA. We've just recently recruited someone for the London area, and we've also got an occupational therapist that covers the northeast. So we've got 5 nurse specialists and 1 occupational therapist. Certainly out of the nursing team, we're all quite happy to talk about sexual function. So, and when I say nothing's taboo, we'll figure out what the question is first before we give you the answer. But really, you can ask us anything. And we've got one of our support coordinators online today as well. And I think our support coordinators, they're quite happy to talk about various aspects of spinal cord injury, from their own lived experience. So without further ado, I will share my screen. Can I just ask, perhaps Andy, if you can just give me the thumbs up, if you can see that title slide on the screen. Yeah, brilliant, thank you. So like I say, I'm the spinal cord injury nurse specialist for the southwest. But just to give you a bit of my history, I worked at Salisbury Spinal Centre for 25 years as a clinical nurse specialist there, primarily in the outpatient department. And I was going out to see patients after discharge, wherever they might be. And my role at SIA is quite similar in a lot of respects. I'm still out on the road, slightly bigger patch, but I do a lot of teaching, training, education. But I'll go out and see our patients wherever they are as well, and that can be pre-admission to a spinal centre, or or it can be post-discharge. And I'd encourage all of you, particularly the guys at Pinderfields, do become members of the Spinal Injuries Association, because we do offer you lifelong support. And membership is free, so we're not going to be asking you for any money. The only thing that you would need to pay for, if you wanted to, is our quarterly magazine, which I would advise, it is worthwhile. It is 4 editions a year, but it's packed full of useful information, and it's just one way of keeping updated with what is going on sort of within the world of spinal cord injuries, because we're very much focused at looking forwards as well, rather than just dragging up information that's already out there. We've got a very good active team supporting us to make sure that we can give you good, current, up-to-date information about what's happening in the world of spinal cord injuries in a fairly broad sense as well. And I think just in the recent edition, there was quite a lot of information about sexuality and sexual function within that. And this is really sort of complements some of that information that's been posted on our magazine already, and also onto our website. So first off, and I think you can probably all identify with this, I'll just go through it. But basically, when you have a spinal cord injury, and I'm sort of looking at the guys in Pinderfields, particularly, it is a major life-changing trauma, irrespective of how it happened. And we don't take that for granted at all. And quite often, when people have a spinal cord injury, trying to adapt to their new life can be quite difficult at first. And certainly, trying to manage that sort of change in body image, to all of a sudden being up on your feet, for some of you being wheelchair users, just how that whole change in body image can impact on the way that you feel, as well as sort of trying to manage everything else that's going on, with your spinal cord injury as well, and how that impacts on you. I put there, loss of identity. I think to a certain degree, it's really just sort of learning who you are again. You're obviously the same person, but how you deal with your spinal cord injury, I think how that can affect yourself, and also just how that can affect friends, loved ones around you, that can take quite a lot of getting used to. And we offer support with our support coordinators. We also have a very good counsellor who has the spinal cord injury himself, and that's a free service that we offer, because I can say, well, I know what it's like to look after people with a spinal cord injury. I've got that experience, but I don't have the experience of living with a spinal cord injury. So hopefully what I'm talking to you today will sort of resonate, but suffice to say that if you want to talk to someone that can really understand, do utilize our support coordinators, or our counselors that can share that lived experience. And I'm sure that they will identify with a lot of the thoughts, feelings that you're going through right now. I put there as well, your body becomes public property. So many times I've heard that your dignity flies out the window when you go into hospital, and I'm sure you'll understand that when I say quite often you get into the spinal center, or wherever you might be, one of the first things that happens is that you're stripped completely naked, because if you're on bed rest for a period of time, it's a good way of making sure that when you are being turned every sort of 2-3 hours, to be able to check your skin. But being reliant on somebody else perhaps to help you, to turn you side to side, and sort of being stripped of your clothing, being stripped of your dignity, that's something that takes a little while to try and come to terms with as well. A lot of the care can be quite intimate, quite personal as well. Thinking about the bladder and bowel side of things, things that you would take for granted, having to rely perhaps on somebody else to support you with that, and just the everyday tasks that I put, on there, just the everyday tasks might take a little bit longer. Just getting up in the mornings, getting washed, dressed, into your wheelchair, it can take that much longer, use up a lot more energy. So even the thought of having sex for a lot of people, by the time they've done all that, they might not have much energy for a lot else. So, trying to deal with the tiredness as well, particularly in those early stages where you're using your body in a different way to get from A to B. And perhaps just using muscles that you weren't necessarily using in the same way before. Pushing around in a wheelchair takes a lot of effort. Getting yourself washed, dressed into the wheelchair takes a lot of effort. So, so dealing with all that as well. I did say I'm just going to give you very, very little anatomy and physiology, and I'll stay true to that. But I think it's important just to understand a little bit, because that will help you understand why it is that one person might be managed one way compared to somebody else. So I'll just leave this slide up there for a moment. It's just to explain, just with our spinal vertebra, that essentially we've got 33 spinal vertebrae, sort of split between the 7 cervical, 12 thoracic, 5 lumbar, the sacral, and the coccyx. And the coccyx is just a redundant piece of anatomy that's been left over from evolution, from the days that we used to have tails, but that's long gone, hopefully. And I'm not going to use too much medical jargon and medical terminology, but again, sort of just looking at the guys at Pinderfields, hopefully you've all got an understanding of what your spinal cord injury level is, whether you've got a cervical injury, C1 to C7, thoracic T1 to T12, lumbar L1 to L5, and so on. Because if you can understand what your spinal level is, again, that will just give me an idea of what your specific issues might be. So I promise you, this is going to be the last bit of physiology that I'm going to talk about before we just get onto the real sort of nuts and bolts about sexuality and sexual function. So your spinal cord is basically an extension of your brain, and it runs through your spinal vertebra, through the spinal canal, and it ends around this sort of T12 L1 level, and then you've got your conus medullaris, which is your reflex center, and that's quite important in the context of what we're talking about today, because some of you might get reflex erections that you have no control over, particularly if you've got a spinal cord injury that's T12 level or above, where your reflexes would be intact. And one example of a reflex is spasm. So, for any of you that can get reflex spasm, chances are you would get a reflex erection as well, because it is a simple reflex. And I'll talk about that in a little bit more depth just as we go on. But below that conus medullaris level, you've got the cauda equina. And cauda equina is the Latin term for horse's tail. But someone that damages these nerves, their reflexes will be absent. So these will be the people that will have no spasticity, no spasm. And for any of you that have seen the film Avatar, working in the field that I do, as soon as I saw, that main character that was in a wheelchair, I thought, well, he's got a lumbar cauda equina injury, because he's got those skinny legs, so clearly doesn't have muscle spasm to maintain the muscle tone. Otherwise, if he had a higher level injury, he'd have better muscle tone in his legs. So it's just, I think, nature of the job. You can't help but spot some of these things. Don't get me started about the bone collector, because that was just completely inaccurate in a lot of ways with some of the things that they were mentioning there, particularly when it came to autonomic dysreflexia. But Avatar is a good representation of someone with a very low nerve damage in the lumbar area. So that chap probably wouldn't have spasm. He probably wouldn't have a reflex erection either. And I'm not sure whether they'll incorporate that into the next Avatar movie, but maybe we'll have to wait and see. So that's all I'm going to say about the physiology side of things. That this conus medullaris, this is almost like a point of anatomy that helps me to understand if someone's got spinal cord damage at T12 level or above, the way that that person would present, they would present in one way. Below that level, they would present differently. That's if everybody follows the textbook. And I know from my experience, often the textbook goes out the window, particularly when we're talking about incomplete spinal cord injuries. That's just a whole different ball game. And you literally have to play detective to a certain degree, and you're dealing with the person and how they present in front of you, which from a nursing point of view makes it really interesting because you are dealing with the individual. You're not just reading from a textbook and saying, well, this is what should happen. You have to look at the individual and treat them very, very specifically that way. Sorry, just to go back to this slide as well. I'm going to break my promise and say that was the last bit of anatomy physiology I was going to talk about, but I guess what's really important are the nerves that affect sexual function, and they're right down here. They're in the sacral spinal nerves, and it's S2, 3, and 4. And those same nerves affect not just sexual function, but also bladder and bowel function. So the reason that's important is that it doesn't matter, where you might damage your spinal cord or where you might damage this area here, the cauda equina, because the nerves that affect bladder, bowels, and sexual function are right down here. Inevitably, there's going to be that those messages are going to come across, that brick wall where that sort of damaged area is, where your spinal cord lesion is. So subsequently, most people with a spinal cord injury, they will have some bladder, bowel, and sexual dysfunction of varying degrees. So before we talk about sexual function, we try and address the issues around sexuality as well. And sexuality and sexual function, they are quite different. Basically, sexuality is how we identify within ourselves, and that includes whether somebody is lesbian, gay, straight, transgender, the LGBTQ plus spectrum. Because from as a healthcare professional, it's really important that we don't just think of someone as being talking about sexual function from the perspective of someone that's heterosexual. We have to talk to people across the whole spectrum of their own sexuality, because everybody is entitled to express themselves, irrespective of what their sexual orientation is. But sexuality also includes things about just our own body image. And I often give the example, maybe stereotypically, of the female patients that come through. So again, I'm really trying not to stereotype, but even for the guys as well, just how you present yourself. If you have a spinal cord injury, that means you're not going to be able to, I don't know, style your hair in the way that you want to style it, shave, independently. How you present yourself might be different to how you would normally present yourself if you're able to manage everything yourself. I hope that makes sense. And so from the female perspective, it could be how that woman applies her makeup, how she styles her hair, how she dresses. And I'm trying to see on that very, very small little thumbnail picture of you guys at Pinderfields, just seeing what you are wearing, because quite often there's almost like a uniform when it comes to going to spinal centers, and that uniform will be jogging bottoms, t-shirt, because it makes life that much easier, particularly from a therapy point of view. It's much easier to wear shorts, jogging bottoms. But I've dealt with so many people that would never be seen dead in a pair of jogging bottoms ordinarily, but they might dress differently, whether that's wearing a suit, but wearing a suit day to day for rehab isn't perhaps the most practical of things to be wearing. So that's all goes back to almost like the loss of identity as well, that how we dress is one way of expressing who we are. So it's all part of our self-identity. So I guess the bits that most people are interested in is about the actual sexual function perspective of spinal cord injury or cauda equina. So, and the question that I get asked is, will it work? If it doesn't work, can it work by different means? And if so, what can I use to help me to get an erection? So there are various ways. I spoke a bit, just about, reflexes, and erections can work as a reflex. And there's two different ways that can happen. That can be, just through physical stimulation. So, you might have no sensation below your level of spinal cord injury. But, if you've got an indwelling urethral catheter in, just simply having that catheter in the penis going up into the bladder, that I say sensation, but the physical stimulation of a catheter running up through the penis could be enough to trigger a reflex erection. It might be if you need support to have a wash, just that physical stimulation of just washing around the genital area can be enough to get an erection. You can get a reflex erection through bowel care as well. And I think this is really, really important to try and get this across, because I've dealt with lots of patients before that have felt quite embarrassed. Perhaps when I pitch up, I'm 6'3", I'm a big fella, and if when I was working on the wards, and I'd come up and say, right, I'll be looking after you today, and I'll be helping you to have a wash. Some of the patients will probably think, well, how come I've got you and not the 21-year-old good-looking female nurse? There's not a lot I can say to that, but maybe it's just a little bit of bad luck depending on which way you look at it. But I'd always be very careful about explaining what I'm doing, and and if things happen, to explain why it's happening as well. So this is just a simple reflex. It might be that it can be triggered just through the bed sheet on your genital area. Something as simple as that, just your clothing in touch with your genital area can be enough just to trigger a reflex erection. There's not a great deal that you can do about it, but from a sexual function point of view, knowing that if you can get that reflex erection, that means when it comes to the point of sexual intercourse, there are better ways, or there are some more options on how that can be managed as well. So that's not the only way that you can get an erection, through the physical stimulation. There is another term, and I did say I'd try and steer clear of some of the terminology, but a psychogenic erection is basically having those sexual thoughts. So whatever turns you on, whatever makes you aroused, if you have those thoughts, that can help you to get an erection as well. And there's slightly different nerve pathways there, but essentially, whatever turns you on, when you're thinking about what turns you on, that can help you to get an erection. I must say that it's probably harder to maintain an erection that way, because I don't know, if you like me, easily distracted, and you start thinking about what you're going to have for dinner tonight, then it's not always the best way to try and maintain an erection. But you can use the combination of that physical stimulation, and the sort of thought induced nerve pathways as well, to be able to get an erection. But it might not be sufficient to be able to maintain it. So that's where some of the medications come into effect, and I'll explain what some of those are in just a moment. So I think one thing that does concern a lot of people is that until you can sort of get a good control over your bladder and bowels, and that might take a little bit of time, because I think when people have a spinal cord injury, you can argue that often they might be doubly incontinent. I would argue that with good management, you can maintain continence very, very well. Unfortunately, sometimes accidents might be unavoidable, and depending on how you manage your bladder, that might sort of give you a few more options as far as what you can do to sort of reduce the risk of the bladder emptying, spontaneously, or just emptying when you don't want it to. If anyone does have a urethral catheter in, you can still have sex with a urethral catheter. What I would suggest, though, is that if you're in a relationship and your partner is of childbearing age, and you're not looking to start a family, just take the usual contraceptive precautions, because accidents can happen, and they can be the best accidents in the world. But if you're not planning on starting a family, just use the normal contraceptive precautions that you would do ordinarily. And I will talk a bit about that as well, just as we go through. But as far as how you manage your bladder, a urethral catheter, that can just be simply doubled back on itself along the shaft of the penis. You can stick a condom over the top. But what I would suggest is that if you are going to put a condom over the top, make sure that the penis is erect first, because if the penis isn't fully erect and you've doubled the catheter back on itself, you don't want to cause any trauma if the penis suddenly starts to get erect and then it's really, really tight, where the catheter goes into the penis. Generally speaking, that wouldn't really be the best long-term way to manage somebody's bladder. More often than not, we would be looking at things like self-intermittent catheterization, just to make sure that the bladder can be completely empty and you can be tube-free. Some people might have suprapubic catheters, where the catheter, instead of going up through the penis, goes in through the tummy into the bladder. So that helps just keep the genital area tube-free. Some people might use a condom sheath because their bladder might just feel spontaneously empty. They may not have control over when the bladder empties. But when we're talking about reducing any sort of unwanted accidents, so sometimes just the timing of passing a catheter, make sure that the bladder's nice and empty before you have sex. If someone does need a condom sheath, there's nothing to stop you from passing a catheter to completely empty the bladder. Or if you're able to empty your bladder yourself, just knowing that you've got a nice empty bladder, so the risk of having accidents would be minimal. And it's the same with the bowels as well. I put there, accidents may be unavoidable, but they're not common. And I can honestly say, hand on heart, in the thinking of the date now, 26, 27 years that I've been working in the field of spinal cord injuries, it's been very, very rare that people have had accidents with their bladder and bowels while they're having sex. We want to try and make it as spontaneous as possible, but if you've got a good daily routine, yeah, I think I'm not sure anybody does have a routine quite like this, but if they do, fair play to them. That's quite some routine. But if you can time having sex around, your bladder or your bowels, or if you know what's going to trigger your bladder and bowels, to be able to manage that accordingly. I know that sounds like it's going to take away some of the spontaneity, but I think you can still be spontaneous, very much so. But if you can manage your bladder and bowels effectively, that can take away some of the anxiety that I know a lot of people with a spinal cord injury or cord recliner might have. That fear that, well, if I'm going to have sex, am I going to have an accident at the same time? The simple answer is highly unlikely, but if you're prepared, then those risks are going to be absolutely minimal. And I think what's also important is just having that conversation with your partner as well, so that it doesn't come as a surprise. Sort of being open with them about the impact of your spinal cord injury, how that affects you. If your partner understands that, then they're going to be more sympathetic, and you can just prepare yourselves as well. Nothing wrong with just putting a towel on the bed, or having like a mattress protector. Hopefully you'll never need it, but it's there just in case. But certainly when it comes to the bowels, if your bowels are empty, or as empty as they can be, again, that's just one problem that you don't have to worry about. So again, to the nitty-gritty. So for those that might still be able to get a reflex erection, and that will be the majority of people, but what can happen is that they might get a reflex erection, but they might not be able to maintain it. So these medications can help. They won't work for everybody, but I think they will work for most. Most of you are probably familiar with Viagra. It's been on the market for quite a few years now. When it first came out, it was limited to people with certain conditions that could access it, and you'd only be allowed 4 tablets a month as well, which for some that was plenty, but for others just not enough. Thankfully, things have changed. You can buy Viagra from your local Boots the Chemist now. The pharmacist will probably just ask you a few simple questions just to make sure that it's not going to interact with any medication that you might already be on. And one medication that it could interact with is, if you're at risk of autonomic dysreflexia, whatever medication you might take for that, whether it's GTN spray or nifedipine. It doesn't mean you can't use it. It's just to be wary of how it might interact, because essentially those drugs, they work in a similar way, and that's by dilating the blood vessels. But with the Viagra, Cialis, Levitra, they dilate the blood vessels around the genital area because that's where it's needed. But what it can do is just lower your blood pressure a little bit. And if your blood pressure is naturally low, or if you take medication for autonomic dysreflexia, which could lower it even further, having this medication in your system, the two medications might interact. But it's not something to be worried about. It's just something to be aware of. And I've not had any patient say to me that they've ended up fainting as a result of the interactions with the medications. But like any medication, just read the instructions. Make sure that it's not going to interact with anything else that you might be taking. And for those of you that are in hospital at the moment, the Pinderfields guys, the pharmacists will pick up on that. So it shouldn't be anything to worry about at all. The medications, it's not just a matter of you take the tablet and you end up with an erection. It doesn't quite work like that. You still need that physical stimulation to get that reflex erection. And then what the medication will do is just help to maintain it. Usually, the doctors will prescribe a lower dose. So that's a 100 milligram Viagra tablet there, but they'll come in 25 milligrams, 50 milligrams, and a lower dose might work, might do the job. And when I say, read the instructions carefully, certainly with Viagra, it must be taken on an empty stomach. Nothing to eat or drink an hour before or an hour afterwards. Otherwise, it's probably not going to be as effective as you would hope it to be. So if you've been out, had a couple of beers, had something to eat, you get home and you're feeling that you want to have sex with your partner, and then you take the medication, it might not be as effective, or you might wake up the next morning with an erection, and it might not be the right time for you. Viagra stays in the system a relatively short period of time, so about 8 to 12 hours. And that doesn't mean that you can end up with an erection for that full length of time. It just means that the medication's in your system so that, with the physical stimulation, the medication can still help you to have an effective erection and hopefully maintain it. With Levitra and Cialis, they work very, very similarly. It's just you can be a bit more spontaneous with it. You can eat and drink with them as well. And the medication stays in your system a bit longer, sort of 24, 36 hours. So it does have its advantages. One side effect, though, which isn't particularly common, but it is a side effect, a known side effect, is that these medications, they can give you a bit of a headache. So you might feel in the mood, and then you pop the medication, and then all of a sudden you've got that, oh my God, I've got a headache. And, that might be a bit of a mood dampener. You might not perhaps feel in the mood at that point. But if you know that that is going to happen, you can take paracetamol at the same time. That will counteract the effect of the headache. So you can take the medication quite safely, take paracetamol if you know that it's going to give you a headache, and that will counteract that quite successfully. So the next slide is quite often the one that, if I look at the people that I'm talking to, this is the one that's going to make your eyes water. This is just another alternative. It's called Cavaject, and it's an injection that goes into the penis directly. So I think for a lot of people, just the thought of sticking a needle in the penis to get an erection isn't the most appealing. I do know of a few patients that use this system, and it does work very, very well. But I think the medications like the Levitra, Cialis, Viagra, they work very effectively as well. So, this Cavaject injection isn't necessarily, the first option that I would be talking to patients about. Just a word of warning, if it is offered to you as an option, it's very important that you are shown how to use it and where to actually give the injection as well, because you don't want to give it into some of the major blood vessels, sort of the top and the bottom of the shaft of the penis. But it does work very effectively, and I think the people that do use it, often they don't have that sensation there. So for most people, it's not going to be uncomfortable giving the injection. It's more just the psychological aspect of injecting into the penis. But what I want to try and get across today is that there are different methods for different people, and it's just figuring out what might suit the individual best. And another option might be use of a vacuum pump. For those that can't get a reflex erection, they can still have sex. The vacuum pump is just a very simple way of getting an erection. And basically what it does, it creates a vacuum which encourages the blood supply to the penis to get an erect penis. And then you have these restrictor rings that go over the base of the penis that just stops the blood from going back into the circulating blood volume. So it keeps it where it needs to be. These rings, hopefully you can see on the screen okay, but they do come in different sizes as well. And it's important to get the right size, for the individual. If it's too tight, that could cause trauma. Without trying to scare anybody, you don't want the blood to clot in the penis. It just needs to be tight enough to hold the blood there. And you certainly wouldn't leave that constrictor ring on, for a sustained period of time. So another question that we do get asked as well is, can I have children? And the simple answer is yes. As men, we're still fertile up to the day we die. What can happen is that the sperm levels can drop, and they can drop quite significantly. But at the end of the day, it only takes one viable sperm to fertilize an egg. A lot of people with a spinal cord injury might not ejaculate, and there are ways to encourage ejaculation. Equally, people with spinal cord injury, they can ejaculate as well, or they might ejaculate in a different way, which I'll talk about just on the next slide. But although we know that the sperm levels will drop, it's that old adage that the more you use it, then the better it will be. So the more that you can encourage ejaculation, then the sperm levels will increase. But there's various factors as to why the sperm levels will drop following spinal cord injury. And particularly for someone that is a wheelchair user, the testicles do need to be kept cool, and that might not always be possible when you're sat in a wheelchair. But certainly when you're in bed, just allowing a bit more freedom to allow the testicles to cool down a degree or two, that can help. But to encourage ejaculation, some people, they will still ejaculate. It might just take a lot longer. It might just take a lot more physical stimulation to be able to ejaculate. But some people might ejaculate more easily, with one of these two options. They're both vibrators, but they're not vibrators in the sense that somebody would use internally. These are not internal vibrators. They have these vibrating plates on them, and they vibrate at a certain frequency that can trigger like a reflex ejaculation. These are a piece of equipment that you may come across at Pinderfields. It might be discussed with you. If not, you can come and speak to us as well. But ideally, if you're going to use something like this, you should be shown how to use it. And I wouldn't necessarily say use it under supervision, but I think if you're shown how to use it and you've got a clinician available should you need support, they're quite safe things to use. Literally, it's just this vibrating plate that goes on the head of the penis. And this one works in a very similar way. It's got two vibrating pads that you just gently squeeze around the glands of the penis. But they can help just trigger that reflex ejaculation. The way that you ejaculate, if that does happen, it might feel different. You may not feel anything at all, but it might just feel different to what you remember it from before. It can trigger autonomic dysreflexia as well for those of you that have got a T6 spinal cord injury level or above. But the important thing with autonomic dysreflexia is that as soon as you eliminate what's causing it, then those symptoms will subside. So when it comes to ejaculation, it's only going to last a few seconds at tops. So it's not something to be concerned about. It's just you may get those early symptoms of autonomic dysreflexia if you were to ejaculate. But not everybody does ejaculate out through the penis. A lot of people with a spinal cord injury, they might ejaculate back into the bladder, and it's called a retrograde ejaculation. But it just means that instead of going that way, it goes back up into the bladder. Doesn't cause any issues with urine infections because it's all sterile. Some people might not even realize that they have ejaculated. It might just be that the urine looks a bit different, that's all. Another way of artificially stimulating ejaculation is through this electroejaculator, which, this is an internal probe that goes into the rectum and just sort of stimulates around the prostate gland area to help trigger, like a reflex ejaculation. We had a very good elderly consultant when I first started working at Salisbury Spinal Unit, and that used to, show the patients this equipment. This equipment was developed through sort of trying to maintain some of the endangered species within the world, and things like pandas, and he had one that was designed for an elephant. And when he used to bring it out, you can just imagine the look on the patients' faces when he brought out this very, very large electroejaculator. He had a very dry sense of humor, but perhaps not everybody got that. But this might be an option for you, if for those of you that are perhaps looking to have children. Some centers do have sexual function clinics that work very closely with fertility clinics, so the two can work very closely together. So one might help with the ejaculation, the fertility clinic will help with the the actual sort of fertilization of the egg. So whether that's through the IVF route. So it is effective, and I just want to sort of get across the fact that there are different ways and means. If somebody is looking to start a family, some people go on to have children naturally, and that's why I sort of make the point that if you're not looking to have children, but you and your partner of an age where that is a possibility, just take the regular contraceptive precautions. So from a physicality point of view, there are websites that can give you an idea of different types of equipment that might be available to you, because sex doesn't have to be just laying flat on your back in bed, or even sat in your wheelchair. There are different pieces of equipment that can help. This website here, Spokes, is very good. It's got a whole list of different types of equipment that might be useful. It looks like a camp chair, like a camping chair, but it rocks backwards and forwards. And this here, your partner can be laying on there. You can be in this sort of rocking chair to get that motion of being able to have sexual intercourse a lot more easily. These inflatable pillows here, I have got, I'm just going to move the thumbnail images just out of the way, but just to give you an idea, this is called an intimate rider. It's just under £500, which I know is very, very expensive, but this is called an inflatable position master, and it's £26.66. Bearing in mind that you probably won't need to pay VAT as well. It's just a relatively cheap piece of equipment that might work quite well. This is like a masturbating device. It's called a Pulse Solo Essential. and that's just under £75. But have a look on this website. It'll just give you an idea of what equipment is out there that might help you. And as far as other equipment, other information as well, I'll just pop this up there. I have got this on an A4 piece of paper, just with all the website links as well, which I'll drop into the chat function. But it is important to have an understanding of where you can go to get your information. So you can come to us, the Spinal Injuries Association, just start typing into the search bar and you'll find all sorts of information will pop up. SHADA, which is the Sexual Health and Disability Alliance, that's got really good information as well. Street C, again, that will give you, that image there has just got, sort of various ways that you can get into different positions and have sex. Spokes has lots of information as well about other resources that it can signpost you to, as well as other equipment that might help. There is Sex and the Spine as well, and there's also Enhance the UK, which as the tagline says, they're sort of changing society's views on disability, and it's it's to normalize sexual function, sexuality. We want people to be able to talk about it openly, and and that should be the case of where you are in Pinderfields. And I do appreciate that not everybody feels comfortable talking about it. So I don't know how the system works at Pinderfields, but you can talk to the nurses. If the nurses don't feel comfortable, then what they should be doing is at least directing you to somebody that does feel comfortable to talk to you about it. That might be one of the therapists in the unit. It might be the doctors as well, but it should be a topic that you can discuss openly wherever you are. But like I say, you can always come to us as well. So this is pretty much the last slide. When I first found that image, I didn't realize it moved as well, but I think it's probably fairly apt, because I think certainly for those that are newly injured, there can be a lot of anxieties about having sex with your partner, and sort of dealing with your own disability as well, and just often people will have those thoughts that will they still be attracted to me? I can honestly say, from my experience looking after people with a spinal cord injury, the wheelchair is no barrier. Often it can be an open door to get a conversation started, particularly for those that aren't in a relationship. Having somebody come up to you and saying, well, so what happened to you? How did you end up being in a chair? Before you know it, you've got a conversation going, and people are curious. You will see a side of people that that they're just curious about how you had your spinal cord injury. People, I don't know, guess after a few drinks as well, they might be asking sort of quite blunt questions as well. How you deal with that is very much down to you as an individual. But all I can say is that if you've got confidence in yourself to deal with your spinal cord injury and how it impacts on you, being able to have those open conversations with your partner or whoever it is that you're talking to, I think when it comes to sexual function, there are very few barriers there, but I think having open conversations makes a big difference, and just being expert in your own condition. So if you can understand why things work or don't work, or why they might work differently, if you can share that with whoever it is that you're talking to or whoever it is that you're with, then they've got that understanding as well. And I think that sets the groundwork for relationships being a lot more successful. This link, I'll just leave that up there for a second. But yeah, if you do want to talk to us, just go onto the website. You'll see a drop-down box or a tab that says find support now or get support, and wherever it is, there is a drop-down box, and you just put in your individual county. They'll bring up your support coordinator for your area, and it'll also direct you to the spinal cord injury nurse specialist as well. So I'm going to stop sharing my screen. I'm very conscious of the fact I've done a lot of talking, but I don't know if anybody has got any comments, or if anybody does want to ask any questions. I'm more than happy to answer anything that you may have. So I'm aware that you're all on mute at the moment. So if anybody does have any questions, do feel free just to unmute yourselves and do ask.
I have a question. Hi, I'm Daniel.
Hi, Daniel.
How can I get my hands on an electro ejaculation? Can I get that for myself, like at home?
So, sorry, do excuse me. I've got my 3-year-old girl. Yeah. Sorry, just one moment.
No worries, no
worries. Daniel, it's Andy from Spinal Injuries Association. If you chat with Mr. Raza, I think, as far as I'm aware, there was some bits of equipment at Pinderfields for the patients to be able to use. And if you're watching this on recording from anywhere across the country, chat with your spinal injuries centre, because they may have these pieces of equipment for patient use.
Yeah. So with the electroejaculator, that is something that would be used in a clinical setting. So that's not something that I don't think you would be able to purchase yourself. But yeah, as Andy said, do just check, see what is available where you are. With the vibrators, they are things that you can purchase yourself. But again, what I would suggest is, speak to the doctors, wherever you are, or the outpatient team as well. Often it is the outpatient team that would help facilitate, the use of this. I can only speak from my experience at Salisbury Spinal Centre, where, the Ferticare vibrators, they could be loaned out. And I know for some, the thought of using something that somebody else has already used, these pieces of equipment, they're sterilized like, any other medical instrument that you'd use in a operating theatre.
Well, I do have a like a Ferticare Personal. I did purchase one. It's sort of 50-50 when it comes to using it. So I'm trying to have a child with my partner, and I was thinking of, instead of going for in vitro fertilization or paying the absorb, is really expensive. I was talking to a clinic, and they're charging anywhere like 5,000 to 9,000 pounds for the whole process. I have a C4, C5, and C6, and I was thinking, with that electro ejaculator, that would be something that we can be more natural. That was my thought, if I can purchase one. But I'll talk to the clinic. I'll contact my local center and then discuss it with them.
Yeah, and what I would suggest as well, Daniel, is that it is very important to use the equipment in the right way. I have seen only one, possibly two patients that have ended up with electrical burns as a result of those electroejaculators. So, because they do work on varying frequencies, and so there's just a note of caution there. But that's 2 people in 26 years. But, using it under the supervision of a clinician, I would say is advisable. But if you've been shown how to use it, then I guess as long as you feel confident in how to use it, that may be an option for you. But certainly the Ferticare vibrators, or the Vibrect, which is the other one that was on that slide, they can be purchased. They're a lot safer to use as well. So they just work on a sort of almost like a radio frequency, like a vibrating frequency that can be adjusted. But they do come with guidance of how to use them. But they may be a suitable option for others as well.
No, they're good. They're good. They're good. Okay, thank you very much.
Thank you. Are there any other questions at all? I'm just gonna...
One more from Pinderfield, is that okay?
Sorry, I have a question, please. It's Patrick from Pinderfield.
Can you hear him okay? Come closer, yeah.
Can you hear me?
I can hear you, yeah. Hi.
Okay. Yeah, my name is Patrick from Pinderfield. I know you've been talking about equipment for one wants to have a sexual intercourse with a partner. I'm just wondering, are we ruling out the conventional bed? If that is still a possibility, I really want you to expatiate on positions that would be safe for someone who has got a spinal injury.
Yeah, so so did you say, can you use a conventional bed?
Yes, yes.
Yeah, yeah, absolutely. And I think that there's no reason, generally there's no good reason why anybody should be discharged in a hospital bed. Although, I do appreciate, I have to add the caveat that, for some people that might be suggested, particularly in the early days, if you need support, there are advantages of, having a bed that you can raise up and down, if you are, requiring care and support at home. But certainly there's no reason why you shouldn't be in a regular bed, with your partner. And, that if you haven't got any skin problems, that can be a fairly regular mattress as well. There are certain criteria that I would suggest, people should consider, if they're looking to get just a regular bed, regular mattress, to, prevent skin problems from occurring. But at the end of the day, if you're in a relationship and you want to sleep with your partner, there's no reason why that shouldn't happen. You can still get beds that will go up and down that don't look like hospital beds, that come in various sizes, whether that's single, double, king size, that can still have the functionality, if that's what's required, to be able to go up and down. The back can be raised up. But so yeah, being in a normal bed is absolutely fine. As far as positions, then what I would suggest is have a look at some of the links on I think the Spokes website or the StreetSea website. And if I can, I'm just going to see if I can drop a link into the chat function. I think what I might need to do, so I'm not too familiar with how to do it in Zoom. It's given me various options, but I think if you can bear with me just one moment, I'm just going to see whether I'm not sure that that's going to work. What I would suggest is, if anybody wants the information that I've got, it's literally got about 6 different websites on there. Just ping me an email, and I put my email into the chat function. Ping me an email, and I can just email the info sheet out to you. So it'll have all the different websites on there that I know will give you good information, good, accurate information.
Thank you.
You're welcome.
Damian, if you want to send that out to all the support coordinators, then whoever's watching this, wherever you are in the country, if you search which county you are in, get in touch with your support coordinator, and then they can get that information direct to you.
Okay, yeah, brilliant.
Okay.
So yeah, I'll do that. Because yeah, it might just be a useful resource anyway, just to have in your armory. You know, if the support coordinators are out and about, and it is literally just an A4 sheet with about half a dozen links on it, and hopefully that will just give you the information that you do, that you're looking for. Other than that, do just get in touch with us. We're more than happy to have a chat with you as well. And I do appreciate that, for those of you, that are in the spinal center at the moment, it might not be the right time to be talking about this. For some of you it might be, but we're more than happy to talk to you at any time. So don't feel that it's something that needs to be discussed now. That this is your only option. You can talk to us at any point, and we're more than happy to discuss with you on an individual basis. I'm conscious that we've run over a little bit, but if anybody does have any questions, do feel free to ask, or I've put my email in the chat function, and either just get hold of me directly, or come through to us via the website, and myself and any other team, we're more than happy to have a chat with you at any point. So if there are no further questions, we'll wrap things up. But I just want to thank you for your time today. It's much appreciated. These sessions always work much better when we've got people